have our panel kind of put their cameras on and enter into the group here. There's been some questions about the use of Indocin or radiation after the osteoarthritic elbow has been debrided. Maybe I'll start with Graham. When you do an osteoarthritic debridement, do you place patients on Indocin? And I know you've had a few case reports. I've had a few of my own of HO after elbow arthroscopy. That's quite rare. How do you treat your patients, Graham, after the debridement for arthritis? Do you use radiation or Indocin or nothing?
Well, I've never used radiation for an initial debridement. I've used radiation after someone's developed heterotopic bone and I'm going back to take it out. For the patients for rheumatoid patients, we don't use indomethacin because the incidence of heterotopic ossification is quite low, although I have seen it, and again recently, unfortunately, in a total elbow, but not in the setting of arthroscopic synovectomy. But I think for the osteoarthritic case like you were showing with extensive bony debridement, there might be a role for indomethacin, but there's really no evidence-based medicine which would support it. I think we need some good research to show that the risk of it is worth the benefit, and I think right now it's dealer's choice. We're tending to use it for patients who have extensive bone removal with no contraindications to anti-inflammatories.
I think I'll just poll the panel. Buddy, when do you treat the patients at all after you debride an osteoarthritic elbow?
No, I don't use Indocin. And if they're high risk for HO, if they have a past history of it, I'll do radiation therapy. That's the only thing I've found to be effective. I don't do Indocin.
And Julie?
I do prescribe Indocin. It's important to recognize that patients will often have GI complaints and may need a proton pump inhibitor. And it's unclear to me how compliant they are with it.
And Larry?
Yeah, I think Graham's point about outcome studies to evaluate its efficacy and risk-reward is important. With that said, I will commonly use it, and particularly in those elbows where there's a very reactive, somewhat hypertrophic osteoarthritis. In those patients, I'll uniformly use it unless it's contraindicated. I think when HO happens, it can be really severe, and avoiding that complication when possible to me is outweighs the risks for those patients in whom I'm very particularly concerned.
And moving on to another controversial topic, so to speak, is the use of CPM, bracing, no bracing, physical therapy after a release of a stiff arthritic elbow. I think I'll start with you, Larry, in the post-operative regimen for these patients. How do you approach the use of braces, CPM, physical therapy? How do you approach these patients?
You know, for those patients in general, I do not use CPM. We've had difficulty getting reimbursed for that, and I've gotten away from that over the years. I will typically splint the patient in full extension. It's in part to demonstrate our ability to get full motion. I think it's a good opportunity to demonstrate to the patient that we've been able to do it. And after 24 hours, we'll start therapy. I rarely admit the patient. On occasion, I will. In revision settings, I might. But no, an index operation, I routinely want. I'll splint them in extension and then do relatively aggressive physiotherapy for a couple of weeks. I often, in that situation, will use indomethacin as a supplement. And for the most part, that's been my post-operative course.
And Julie, what's your approach to the post-operative regimen?
Like Larry, I'll splint the patient, generally in full extension, and have them start hand therapy. I generally don't use CPM. I will use bracing protocols under the supervised hand therapy program.
And Buddy, what's your approach to the physiotherapy and CPM issue?
Yeah, I use CPM. I'll admit them overnight with a drain. I use CPM. They get an OT consult right away to start hand and wrist exercises, as well as to show them the stretching. I also use an interscalene catheter indwelling overnight so that the arm stays pretty numb and they can move it very well. And then they'll start physical therapy the next day, and I send them home with a cryocompression device. If their insurance, if they can get CPM, I'll keep using it. I think it's just helpful to have it move. If they can't, and I definitely want them in therapy every day. And then again, I don't do Indocin. If I'm worried about it, I'll add some prednisone to it to try to decrease that. It does increase, I think, your rate of fistula formation a little bit, but I think it decreases the inflammation as well.
Great. And Graham, what's your typical post-operative protocol?
Well, it's probably a bit of everyone's, really. I mean, I think there's the OA case with minor contracture and minor bone removal, and we tend to do those as outpatients, and I don't even put them in a splint and extension. I just give them a soft dressing and get them to take it off themselves in a couple of days and move it. For patients with, extensive bone removal and significant pre-op stiffness, often where I've released the ulnar nerve as well, those are the ones I treat more like Buddy, where I'll admit them, leave a catheter in, leave a drain in, get them going the next day with a therapist with splints. If they're more severe, I'll use a CPM, but I tend to use less CPM now than I certainly used to in the past for simple primary OA of the elbow. I think it's the post-traumatic OAs, which we don't often talk about. They're they behave differently. They're kind of bad actors compared to primary OA of the elbow, where I think we kind of get away with a lot more.
Yeah, I think my approach has evolved also. I send everybody home the same day, and I put a compressive dressing on, and I try to see them back at 2 days if they're reasonably local. And I kind of tell the residents and fellows I like to see the hand a little swollen. So when I take down the compressive dressing on the elbow, there's no swelling at all. I'm concerned about the moving of swollen elbow right out of the box, so to speak, before they had a chance to clot and to calm down. But after 2 days, the elbow looks really unswollen. I then evaluate the patient as far as their pain tolerance, and if they look at me like it's my elbow and they don't want to move it, and they really have a poor pain threshold, at that point I'll admit them for CPM and a block. But again, that's become less and less. And most patients, if they're a local farmer or plumber or a hardworking guy, they often say, start moving right away, and I say, just get back to work. And the average office worker, I'll give them a splint to work on flexion and extension. And I'd say probably now more and more patients are going to therapy and just using the elbow to get motion. We don't have any good data in the elbow as far as CPM. We have good data in the knee, at least with knee replacement. That doesn't seem to make a difference after 6 months or so, but we just don't quite have that data in the elbow yet. I think Graham kind of touched upon the ulnar nerve a bit. That's a question that sometimes comes up, is you have a patient that comes in with a stiff arthritic elbow at 90 degrees of flexion or less, and I'd like to pull the panel and approach if the patient does not have any ulnar nerve issues at all, but they're only flexed to 90 degrees, and you plan on doing a good arthroscopic release, and you think you can get a good arthroscopic release. What is the approach to the ulnar nerve, if any, at all? And maybe I'll start down at the other end with Graham. Why don't you tell us your approach to that patient that does not yet or have any ulnar nerve issues?
Yeah, well, there's two types of I don't have ulnar nerve issues. One is they don't complain about it, and two is when you examine them, they've got a Tinel's over their ulnar nerve, and it hurts when you push on it. I think those are, sometimes they don't complain about it because they're complaining about their elbow in general, so you need to examine the patient to look for it and to look for that, minor intrinsic wasting. Some people present with wasting and not even numbness in this population. Some of them are pretty stoic people, but the 90 degrees is a big worry for me, and it probably depends, how much flexion you're going to gain. Some of the people I treat are, on the juice. They're bodybuilders. They've got such big muscles, they're bigger than my legs, and they're only going to get 120 degrees of flexion, or even 115, because their muscles hit each other, unlike mine personally, as you can probably see from the video. So I think that. Yeah, so I think that, it depends on what you're going to gain, but at 90, I know I do currently an in-situ release of the nerve. The only question is, would I actually move it? I don't think I need to move it if they have no symptoms, so I do an in-situ release at 90 degrees. Sorry, long answer.
And other panelists, anything different than what Graham does, or very similar?
Probably very similar. I like to palpate the nerve and see if it moves in the groove. I think one of the things that we kind of don't really talk about is you can palpate where it is, and there may be some spurs underneath it that you can get out arthroscopically, but the nerve is very flexible. It's in a nice bed, which is often the primary osteoarthritic. But post-traumatic, where there's scarring in there, I think you have to release it. I think those are the ones that really get you in trouble when the nerve's not moving at all. So if it's fixed in the groove and you can't move it back and forth a little bit, then along with the things that Graham said, I think you have to release it. I don't ever transpose it as part of an arthroscopic procedure, but I'll release it. Now, if it's been released before and we're going back in for a revision, then I may transpose it at the same time.
Julie, your thoughts?
I agree with what Graham and Buddy have said, and I think that Graham's point about the patients that are asymptomatic is you have to really specifically ask them about symptoms and just specifically examine them for ulnar nerve symptoms, because many of them will be quote-unquote asymptomatic and actually will have some level of ulnar neuritis, and I would do a in situ release. I have a fairly low threshold for that.
And Larry, your thoughts?
Nothing really to add other than for that patient you described with 90 degrees of flexion, I think the risks are significant for post-operative ulnar nerve symptoms, even if they don't have them. I think the risks of the intervention, whether it be an in situ decompression or even arthroscopic release for those that are comfortable with it, is low. And so I tend to lean toward a decompression in some way for that particular patient.
Yeah, and I don't have that much difference with the panel. If a patient truly is non-tender, and I think ulnar nerve can present as simply as elbow pain. So as Graham and Julie were saying, you need to examine the medial side of the elbow. But if in my exam they really have no ulnar nerve symptoms and they're stiff, I will just do an arthroscopic release, and I've been doing that for years, and I've not had an issue with a new post-operative ulnar nerve develop after that. But I would echo what Buddy said. If it's a post-traumatic situation where there's been either surgery or scarring over the medial side of the elbow, I think you kind of have to expose the ulnar nerve. That can get you in trouble if it's scarred down and you free up the rest of the elbow. You can get a significant, I think, stretch injury of the ulnar nerve in that situation. Well, I think we're starting to run out of a little bit of time. Just a couple of questions from some of the people in the audience. The question is doing a significant release of the stiff elbow, taking out the osteophyte, taking out that capsule that's important to take out. Is that a temporary procedure, or is that a permanent procedure? How many times have you guys had to go back and redo, so to speak, or do a second procedure after you've had a successful release and reasonable range of motion afterwards? Let's start with Larry with that question.
And Scott, that's for an osteoarthritic patient?
Yes, and the osteoarthritic patient.
And I've had excellent, maybe been lucky, but I've had excellent long-term results with this operation. And for me, it's an unusual situation for a true osteoarthritic to have to go back and to breed it. With that said, on occasion, they'll develop other loose bodies that require debridement and removal. But for the most part, it's stood the test of time. And maybe I've not been in practice long enough, but it's worked.
Julie?
I have a similar experience to Larry, and it may be that these patients took 40 or 50 or 60 years to get to where they were with their symptoms, and it's going to be a matter of time until their symptoms recur. But my experience is similar to Larry's.
And Graham?
Yeah, I already made a little comment there. I've been in the same institution for 22 years, and I've only redone a handful that I can recall, and I must have be in the hundreds now in terms of what I've done now. I don't think people are going elsewhere, nor do my partners. So I do think it as Buddy has commented there, on the chat room, that I think that's pretty durable, surprisingly. So maybe these people just get less active by the time you operate on them, and they just don't go back to weightlifting or some of the crazy stuff that we all do when we're in there.
Yeah, I think Buddy typed in about one out of 50. Is that about right, Buddy? You're saying when you look back at the follow-up.
We look back actually about 10 years ago, and it's amazing. I mean, when you think about when we first started doing it, we thought we'd be replacing everybody, in just a few years, and thought it'd be quite temporary. But it seems to amazingly enough, like Larry said, it lasts a long time, and these people do well.
Yeah, I've had the same experience. I was actually thinking, how many have I redone, and I haven't actually looked for sure, but I'm pretty sure it's less than half a dozen out of a few hundred elbow arthroscopies. So to me, it's a permanent type operation. I'm fairly enthusiastic about it. I think we're just about at a time. And before I hand things over to Roman, I just want to thank our panel again, Larry, Julie, Buddy, and Graham, and thanks so much for the great talks and discussion. So thanks again, everybody.